In healthcare billing and coding, there are many things that can happen, which leads to payment delays to physicians and practices. Now, these delays negatively impact revenue cycle and create unnecessary administrative challenges for healthcare organizations, causing significant revenue cycle concerns and physician and staff burnout from all the adminitrivia. In this video, I'm going to discuss some of the billing problems facing medical practices and how to mitigate them. For those of you who do not know me, my name is John Lin. I'm a urologist in Gilbert, Arizona, also your humble host of the Thriving Urology Practice Facebook group, where we crowdsource practice management solutions for everyone's benefit, and it is all for free because you know how much I hate information behind paywalls. And those of you who have joined us recently, welcome to the group. This is a safe space, and keep in mind that you can post anonymously in this group. And if you're watching this on a replay, either in Facebook or on YouTube, I welcome any comments, either live or on replay that you're watching. Okay, I'm going to cover 5 different topics. Here are some of the common billing concerns when it comes to insurance billing and coding. Number 1, patient may not have insurance coverage. Some of the denials that we see occur when a patient's insurance coverage has expired, has been terminated, or the patient never got insurance. So it is imperative that you find out beforehand. Also, patients may fail to update their insurance information or simply neglect to renew their coverage when they initially had it. That is why it is imperative, extremely important, that you dedicate staff to verify benefits before the patient is actually seen, before the services are rendered. Because once you render the service, the value of your service goes to crap, nothing. So it is important. You have to figure out the patient's actual insurance plan, their eligibility, their coverage. In addition, the copay, co-insurance, and unmet deductible. And you want to collect that before the visit. You do have to dedicate resources to this task. It is, if you're not doing this right now, you're really, really behind the 8 ball. For the last decade or so, I think over a decade, the biggest bucket of revenue in my practice is not coming from the insurance companies. It's coming from the patients themselves. The unmet deductible, copay, co-insurance. You have to figure out what the patients owe before they hit the door. And better yet, let the patients know what they owe before they come to the practice. Text message, email, secure email, phone call, that has to be made, and you have to dedicate resources. Here's another take-home point. In 2023, for the first time ever, for many years, the biggest bucket has been from the patients themselves. But overall, in 2023, for the first time ever, the amount that the patients paid us exceeded over 50% of the total practice revenue. Yeah, that's right. You're thinking, what? Yes, that's correct. Exceeded over 50% of the total revenue for the practice. It is coming from the patients themselves, not from insurance companies. That is why I keep harping on the fact that you have to figure out the unmet deductible, copay, co-insurance, and collect that up front. You do have to dedicate personnel resources, electronic resources, to make sure that is being done. Okay, number 2, inaccurate patient information. When you put in information in patient demographics, for instance, the wrong name, date of birth, wrong spelling on the name, wrong contact information, wrong policy, wrong group number, or simply the wrong insurance plan, and you think patients are confused about whether they have traditional Medicare or one of the Medicare replacement plans. Unfortunately, a lot of the novice front desk people may not know that as well. So when the call takers are collecting that information, the patients are confused, they give you wrong information, and then you don't, on the back end, check to make sure that patient truly has Medicare versus Medicare Disadvantage or replacement plans. And when these inaccuracies, they can arise from collecting the wrong information, incomplete forms, miscommunication during the registration phone calls, or simply data entry mistakes. So to mitigate that, you have to implement some robust patient registration and verification processes so you can minimize these denials, which are totally preventable. And one of the things that I have taught my staff and also taught a lot of the coders and billers during meetings, the numerous meetings that I've been to, is to use the read back technique, meaning the patients can tell you something and you read back that information to verify that you truly have the correct information. The use of military phonetics, when you say A as alpha or D as in delta and E as in echo, because D and E sometimes when you collect that information over the phone with a poor cellular connection, because most of us are using cell phones, and sometimes the voice quality is not perfect, D and E can sometimes be mistaken. So if you have your staff read back the information and use military phonetics for letters, that may help decrease the frustration, the mistakes in collecting that information. Verifying benefits, again, prior to office visit is imperative in 2024. Actually, this has been imperative for many years, and it shocks me that practices are still not doing that. Okay, number 3. Missing or invalid information in documentation. So some of these claim denials can often result from missing or incomplete documentation, including from the physician and the APPs. Insufficient or inaccurate information such as missing diagnosis codes, ICD-10 codes, CPT or procedure codes or modifiers can lead to claims rejections. Now, using electronic health records can help with some of the coding guidance, and sometimes the claim scrubbing tools on the practice management side from the coders and billers can help detect and rectify some of these issues before the claims actually go out the door. Make sure the electronic health records, assessment and plan ICD-10 codes, and the CPT codes are updated, because these codes are updated literally every single year. So avoid unspecified ICD-10 codes. We covered that recently in one of my interviews with Marianne DeSoyce. So try to avoid unspecified ICD-10 codes. Get rid of that in your assessment and plan. Update the assessment plan to make sure that ICD-10 CPT codes are up to date. In addition, what I do in my practice is that I match multiple diagnosis codes to a single CPT code. And you may know about G2211, the code that started to be paid in 2024. It was actually came to the code set back in 2021, but starting January 1st of this year, it is starting to be paid. If I have multiple ICD-10 codes that I can use to justify the use of G2211, not only will I include BPH with urinary obstruction, and I bring that CPT code, the G2211 under BPH with obstruction, I also include things such as diagnosis codes such as prostate cancer under that same G2211 code. Also, if I am ordering a CT scan, CT urogram, for instance, I include history of the primary diagnosis will be gross hematuria. Okay, let's just say gross hematuria. That's why I'm ordering CT urogram. I also include history of tobacco use under the same CT urogram CPT code. I also include family history of kidney cancer. Okay, I also include history of urolithiasis. I include all of these codes when I order a single CPT code. And that's part of the reason why I don't feel burned out, because I'm not excessively burdened with prior auth peer-to-peer calls. Part of the reason is because I include comprehensive documentation in my assessment plan, number one. Number two, I include all relevant ICD-10s to every single CPT code. So I take the burden off of the coders and billers. My coder, Krista, she doesn't have to deal with that. And my staff will be able to send the order in for the CT imaging, and the imaging center will not have any issues I won't get the pushback saying that, hey, the claim is being denied. The CPT code is being denied because of lack of documentation or medical necessity. So that is why it's important to document completely and then supply all the necessary ICD-10s. I think of these as building blocks to support the CPT code that I'm ordering. You want to keep in mind that computers are doing the first pass claims adjudication. So you want to make sure that you are supplying the computer with all the potential codes to justify your use and order of a CPT code. I know, urologists and APPs, you're thinking, I went through school not to figure out this coding and billing, but if you participate in this third-party payer game, unfortunately, you do have to use their codes and play by the rules of the game so that your patients can benefit from your care. Unfortunately, this is just how the game is played. So don't hate the player. Don't hate the player, hate the rules, right? Okay, issue number 4, coding errors. Incorrect medical coding, such as assigning incorrect diagnosis codes, procedure codes, or using the wrong modifiers, can also lead to denials. So many people are misusing modifier 25. They simply don't understand it. And if you want more discussion about modifier 25, you can go on YouTube, look for modifier 25 John Lin, and there'll be no fewer than 5 or 6, possibly 7 videos talking about modifier 25, and most of it are specific to urology. So make sure you review those so that you can use these codes appropriately so the claims are not being submitted and then being rejected. You're causing your coders and billers more work by not including these codes and using these modifiers appropriately. If you do apply these codes correctly, comprehensively, and the claims are submitted, the amount of time that it takes for you to submit the claim and then the money hitting the bank is greatly shortened. So your revenue cycle is greatly shortened. And for me, I look at a metric called the gross charges days in AR, and I look at it over the last 90 days. I look at this every month. For us, if the gross charges days in AR over the last 90 days exceeds 20 days for me, that becomes a problem. So typically, we're getting between 15 to 20 days, somewhere around 18 days or so, from the time I provide the service until the claim is fully paid by the insurance company, by the patient, is usually less than 3 weeks, usually around 15 to 18 days, which I know for most people is incredibly short. But follow some of these tactics, follow some of these recommendations that Marianne DeSoyce from PRS Network and myself have been giving you, Mark Painter, you can get there too. So do the work, collect the money very quickly so that money can be used for improving infrastructure, paying bonuses, paying yourself, paying down debt. Makes your life a lot easier. Makes you work a little easier and happier. Okay, so inadequate documentation, lack of coding knowledge, or misunderstanding of the coding guidelines to use the modifiers can result in some of these claims denials with coding. So how do you correct that? Regular training and education for the coding staff and the physicians and APPs, along with internal audits, can reduce some of these coding-related denials. A couple of the resources I will suggest: number 1, Urology Advanced Coding and Reimbursement Seminar, UACRS, by the Painters, also known as PRS Network. You can go to prsnetwork.com to find these meetings that will happen twice a year. The first one will be in December of 2024 this year, and also January 2025. The one in December will be in Las Vegas. The one in New Orleans will be in January 2025. And we will discuss some of the new rules put forth by Medicare, the final rule by CMS, because the final rules are usually released in November. So the folks attending the meeting in December will get the first delivery of this information, and then the folks in January will also get this information. We hold these meetings in December and January so that you can learn the rules and apply them the rest of the year in 2025 in this instance. That's why the UACRS meetings are set at that time. And during these meetings, we also talk about coding, billing. I generally cover modifier use typical of urology practices so that you're not missing out on a lot of payment that are due you. When you do the work, I want you to be paid for that work. Also, another resource is the AUA annual meeting. AUA Practice Management Network also holds coding courses. I think they have one in June, possibly July this year. I think July this year. And I believe it's virtual, possibly online as well. But you can take these courses and learn about coding and billing, some of the basics. Also, another great resource is the Institute for Leadership and Business at the AUA annual meeting this year. I think in a week or two, I'll be there. And Dr. Jonathan Rubenstein, I think, will be presenting a course on the basics of coding and billing. I highly recommend that you consider attending those courses. Finally, another resource is this amazing Facebook group called the Thriving Urology Practice Facebook group. A lot of coders and billers are here, and a lot of APPs and physicians posting questions, asking questions, providing valuable insight and answers. Because here's something, this is such a screwed up system. You can have CMS, Medicare, come up with these rules. And for CMS, for Medicare, if you see a Medicare patient, Medicare Advantage patient, most Medicare Advantage patients, you can apply these rules and it's going to work. But when it comes to private payers, the CMS rules may not work. And that's why a lot of times the coders and billers in this group will post questions. And remember, when you post these questions, you should document where the service is being performed, the site of service. Number two, very importantly, who is the payer? The payer is extremely important. So if we have that two pieces of information plus your problem, we'll be able to answer your questions a lot easier and a lot faster. But these patients abound. A lot of people will comment and leave these questions and comment with the responses and replies of what they have seen, because in each healthcare is extremely regional. Blue Cross Blue Shield is also very regional. So if you have a question in your area, and sometimes when another group, another coder and biller, another physician has dealt with this problem in another area, another geographic area, sometimes you can cross-pollinate and apply some of the tactics that you use successfully in one area in another region. So make sure you utilize the resource, the Thriving Urology Practice Facebook group. Also, prior authorization. This is the last topic, prior authorization and referral issues. Issue number 5. Denials related to lack of prior auth or referral documentation are unfortunately very prevalent for some practices. If you fail to obtain the necessary authorization or referrals for a specific visit or specific procedure or procedures for a specialist visit or consultation, this can result in claims denials. This is somewhat ridiculous because you can contact a certain insurance company and you say, hey, I'm getting a prior authorization for X, Y, or Z. Sometimes, and I don't know if it's deliberate or just pure ignorance by the person answering the phone on the other end, they may say, no authorization needed. No prior authorization needed. If you know that this is a service that has a relatively high dollar value, you may want to get a predetermination. Even though they will tell you no prior authorization needed, get a predetermination. And when you have these conversations, always write down the agent's name, when you called, the number that you called, and also any sort of authorization number or predetermination number that you get. Some practices have resorted to recording that conversation, and when you have these insurance companies, when you call, they always say, hey, these calls are recorded for quality assurance purposes. Well, sometimes if you need to fight back, you may want to say, hey, I had this conversation with this agent on this date and time. Why don't you go ahead and pull that record, pull that recording for your quality assurance purposes? Sometimes you can win that way. And when they try to falsely and I don't know if deliberately, deny your claim. Effective communication with the payers, staff education on authorization requirements, and robust processes for obtaining and documenting authorizations are essential. So, 5 topics that some pitfalls that you may experience in claims denial. Now, in addition to these tactics mentioned earlier, sometimes insurance companies may impose unreasonable documentation requirements on healthcare providers, urologists, medical practices. You may know about some of these, and I would love to hear about what you've experienced in some of these crazy claims denials. Let me know in the comments. As always, thank you so much for the privilege of your time. Please take care of yourself and each other. And at the time of this recording, have a great weekend. Bye-bye.